In some ways, CABG and PCI have a similar framework in that patients can have acute or non-acute presentations. They undergo some sort of diagnostic testing, and then they receive an intervention, either a surgery, a PCI, or medical management. So these are variations on a theme, and you'll see that this big framework comes into play for both episodes. Though we've developed the episodes separately, we're going to have our expert groups come back together again to review the findings and comments of today's meeting. If you go to the next page, page 20, you get a bit of a drill down because we're going to first talk about the PCIs. And again, patients can present acutely with a STEMI, non-STEMI, unstable angina, or they could have some other semi-acute or non-acute presentation, stable angina, change in presentation, change in symptoms, some other finding either by risk factors that put them into a diagnostic evaluation. They at some point likely receive a diagnostic angiogram, and then they go and either receive medical therapy or a procedure. In this case, they get a procedure. And then there's a series of, that would be the trigger for the episode. The procedure itself is the trigger for the episode. And then after that, there would be follow-up care. Complications managed, medications started, and handoffs to the next providers to avoid readmissions or complications or cardiac complications because of adherence issues after discharge. You go to the next page. When we do this, we talk about practice variation. We look for sources of value, and again, in this kind of a pathway, it's looking for the most appropriate diagnostic assessment during the acute or the stable angina presentation. Efficient use of the inpatient stay days or the length of stay, inappropriate use of testing, reduction of complications or operator interventions, good choice or evidence-based choice of therapies, and then appropriate post intervention care, which would be discharge planning, medications, and handoffs. On the next slide, page 22, you can see the if you will, the demography or the population of events. And this is for fiscal year 2000 or calendar year 2011. And you can see that there are more episodes on the Blue Cross Blue Shield side than on the Medicaid side. And that's partly because Medicaid population tends to be a bit younger. There were 481 Medicaid PCIs versus about 1,100 Blue Cross Blue Shield, and this data is for the non-self-insured population of Blue Cross. And you can see the breakdown of STEMIs, non-STEMIs, unstable angina, stable angina, and other events. The number of different operators or providers, 69 cardiologists or interventionalists in Medicaid, and 105 in Blue Cross. The Medicaid cost is quite a bit different than Blue Cross Blue Shield because of the difference in per diem costs, the facility costs, as well as to some variation in terms of physician reimbursement as well. Go to the next slide. You'll see again a bit of the breakdown, and probably no shock here on the Medicaid side. You can see that the STEMIs are more expensive than the non-STEMIs. They probably have a little bit longer length of stay in the hospital. And the unstable angina, stable angina, and others are the least or less costly of the group. And again, probably because of less acute hospitalization activities. And then go to the next slide, just on 24. You see the breakdown of costs for Blue Cross Blue Shield, and they're pretty similar in terms of the ratio, the way the Medicaid costs looked for STEMIs, non-STEMIs, unstable angina. So again, the big picture, and relatively speaking, very similar kind of profiles, relative costs between the two payer programs. At this point, let me turn it over to Dan Tsai, who will walk through some of the details of the, I'm sorry, there's one more slide I was supposed to do. I always forget that slide. Multicolored purple slides, again, shows you costs by time frames. And again, the big blue bar there in the middle is for a STEMI, and no surprise, they have a fairly expensive acute stay with a variety of testing as well as lengthy inpatient stay for the acute event, as opposed to the other episodes, which are much more short-term or potentially even outpatient-oriented. So again, no major surprise there. So let me turn it over now to Dan to go through some of the details of the PCI episode.
Thank you, Bill. So I'm going to start at page 27, and I will spend a few minutes walking through several of the components of the proposed episode design, and then I'll pause, and then we'd invite comments, input, questions, and feedback on this. So starting on page 27, we wanted to start with one comment, which was Bill just walked through a number of different patient presentations for a PCI between STEMIs and STEMIs, et cetera. And clearly the cost of each of those different patient presentations varies because of the severity of the patient. There are different entries into kind of the care delivery system through the ED, not through the ED, et cetera. Those are things that each of the payers are going to be very conscious of. I think as a principle, the episode model for this one and all the other episodes that have been launched so far aim to take into account historical variation in cost and differences in cost due to patient risk and severity. And so the payers will be looking through more detailed data, historical data, across each of these different severity and risk levels to adjust kind of cost to make sure that the model is compares, as fair a comparison as possible across principal accountable providers. And as the details of how that exactly will be done is finalized, those will be kind of posted for feedback as well. So starting on page 28 for the current episode design, the episode is triggered, as Bill said, with a PCI, with an actual procedure. And we'll show some data in a little bit about what's the frequency of different specific codes within that trigger. The episode will start at the diagnostic angiogram for the procedure. In cases where the diagnostic angiogram is separate from the actual PCI or the stent or the procedure, the episode will start before that actual procedure. In cases where the cath converts immediately to an actual PCI, the episode would start at that period. And the episode would continue for 30 days after discharge from the facility that the procedure was performed. And the episode would include all related facility services, whether inpatient or outpatient, all professional fees for any provider that provided relevant care for the episode, pharmacy, labs and diagnostics, other ancillary costs, and so on. I'd also note that readmissions during that 30-day time frame, again, similar to any of the other episodes that have an inpatient or a facility component, would be you would start with an all-cause readmission within a 30-day period, but then there are many exclusions applied to that for readmissions that are not really directly kind of related to the episode. That list is defined by what CMS has put forward for some of these related conditions. So, if you get a liver transplant or some of these other things in that 30-day time frame, those would not be included as part of the episode. Also, at the bottom of page 28, under the exclusion criteria, there will a number of patients would be kind of excluded in the cost calculations, typically because they will be more severe or different cases and aren't where the payers don't want to include those episodes as you're comparing average costs across principal accountable providers. On the first point under exclusions, you'll see the point that says PCIs that convert to a CABG within 1 day. We spent quite a bit of time getting feedback from our clinical advisors who noted that for PCIs, we do see some PCIs that convert to CABG on that same day. In some cases, those may be the result of a complication of the procedure, but in other cases, there are actual clinical reasons why that PCI would convert to CABG in that same day. And because it's very hard to tell that directly from the claims data, when it's kind of justified versus it's an avoidable complication, and it's relatively small number of cases that actually do that. For version 1 of this, the payers have just decided to exclude those cases because those would obviously be much, much more costly than your average PCI. There will also be a number of comorbidities that are excluded. Renal failure, we'll go through the list in a little bit more detail shortly, as well as some other exclusions that you'll see at the bottom of page 28. On page 29, episode adjustments. We already mentioned that the payers will be adjusting based on the historical difference in cost for various levels of patient risk and severity, NSTEMI, STEMI, unstable angina, etc. Very high cost outliers will be excluded as well. So after you kind of make other risk adjustments, if there's still, and after you exclude some of the more severe cases, if there still is an episode left that is over, I think it's 3 standard deviations over the average or something, it's still in there, those would be excluded as well in the calculations of the average cost per principal accountable provider. And only providers with at least 5 episodes per year would be eligible for gain sharing or risk sharing per payer. And then on the principal accountable provider, for Medicaid at least, the PAP will be the physician that performs the PCI, typically the interventional cardiologist, that is associated with the claim form that was billed for the PCI. I'm going to walk through just a few more pages and pause to ask for input and questions. Page 30 visualizes the boundaries of the episode a little bit more. You'll notice, like I mentioned before, that the episode, which is the bracket here you see for episode window, starts at the diagnostic angiogram, or the cath. What's not included in the episode are many of the varied tests and other things that occur before that. While some of our clinical advisors have mentioned there is practice variation at that period and potential sources of value, so do you have overuse in some cases of a nuclear stress test and things of that sort. There are so many different pathways of presentation for this episode. Did someone come in through the ED and therefore had a number of tests that were done on them far before the interventional cardiologist even saw that patient? Because there are so many of those different pathways, for version 1.0 of this episode, the payers have not included any of those costs up front, just to keep the episode a little bit more consistent across principal accountable providers. And as I mentioned before, all the what inpatient and outpatient facility claims, all professional claims associated with providers that rendered care for the patient for this episode, a number of diagnostic, lab, imaging, and pharmacological costs are all included in this, and we spoke before about the readmissions. So 30 is just the visualization of the boundaries of the episode. On page 31, you'll see the frequency of the trigger codes that start an episode. So again, these are the particular CPT codes for which when a payer is looking in historical claims data would trigger an episode. There is a longer list than these 6 listed here, but there are actually no cases for those others, at least for Medicaid. So you'll see here that 79% of all PCI episodes were triggered by a 92980 CPT code for a single stent. 10% had also a stent for each of the additional vessels, and you can see the distribution here. On the following page, you'll see the related diagnosis codes for the PCI episode. And you can see that the vast majority, 41% of the episodes related to the trigger had a 41401 ICD-9 code. 15% had a 4111 ICD-9 code, and you can kind of see the variation here of the different codes related to the trigger for the episode. I mentioned before there are a number of exclusions that would be applied, and the way, so you'll see on the left, patients that are younger than the age of 18 that have a PCI would be excluded from this episode. I mentioned that PCIs that convert to CABG within 1 day are excluded. And on the different conditions that you see on the right side of the page, the way this would work is if a particular patient had any one of these claims in the 365 days prior to the episode, that patient would be excluded from the episode, the calculation of episode costs. So there are things here like end-state ESRD, ventilator dependence, and a few others that you can see here. We would really ask for feedback on this as well if there are other exclusions that would need to be applied. And finally, on page 34, there's a starter list of risk factors here where the payers would look at the historical costs across each of these different risk factors based on claims data to see what differences in costs have been across the state in the past, and therefore what adjustments would be made on a case-by-case basis in the calculation of the average cost per episode.